Welcome back, everyone. We had a great session in this room, and I hope that those of you who moved downstairs had an equally great session. We had hoped to be able to do some quick report backs, but I think the discussions were so rich that in order to stay on time, we would just want to move quickly into the next session. Hopefully later in the day we'll be able to share some report backs from the two breakouts, and if not, these will be online either in video and our audio format so that you can go back and listen to the session you weren't able to attend. So far this morning, we've heard a lot about CDC and their crucial role in global health security and how we can work with them and on their behalf. What we want to talk about now is the crucial importance of giving CDC the tools they need to stay cutting edge, to be able to do what they have to do to protect Americans, to protect population health across the globe. And to do that, Dr. Larry Brilliant, who you had heard introduced earlier this morning, is going to moderate the next panel. And he's agreed to do this last minute, and so we appreciate that. With a name like Brilliant, he ought to be able to do anything. But to tee up this session, we want to, again, just bring everyone and center them around this important issue with a short video.
We never stop. Thanks to technology, we are always moving. Microbes and diseases are growing fiercer and faster than ever before, too.
The threats are real. Almost 50 million people get sick from foodborne diseases every year. We're dealing with microbes who are becoming resistant to almost every single antibiotic that we have at our disposal. We also are incurring enormous costs as a society. Businesses spend $10 billion on costs associated with flu infection in their employees.
Technology has advanced, so with the right tools, scientists can better track deadly organisms like the flu and see how they are spreading.
CDC is the leading public health agency in the world. It's the agency we rely on to detect disease outbreaks anywhere they occur. But what if somebody told you that the technologies that they were using to detect disease are more than 10 years outdated? That there are some junior colleges that have more advanced technology available in their laboratories than the CDC has.
Advanced molecular detection, or AMD, speeds up analyses of microbes. What used to take months can now be done in hours.
We'll be able to identify and characterize clusters of infectious diseases much more quickly and much more accurately than ever before. What this means is that we'll be able to direct public health responses and allocate resources more effectively to a response.
The most important assets CDC has are its experts in disease investigation and tracking, and its specialists in laboratory science and data interpretation. The expertise they have supports and trains scientists around the globe to be able to protect health.
The most significant risk we face now is inaction. AMD will save countless lives and lead to a healthier and more secure American public. If we don't act now, those lives are at greater risk.
10 years ago, the CDC was operating out of dilapidated facilities. Today, they're in beautiful facilities, but with equipment and technology that's outdated. They need the most state-of-the-art equipment, such as AMD, to detect disease threats globally. These threats are no less important than the military threats the country faces.
Hello again, everybody. I'm happy to pinch hit in this because it's such an important topic, and it's really good that so many of you are sticking here. We're just standing now between you and lunch. It's an odd panel to have just before lunch. I'm going to read you the title, and don't be thinking about what you're going to order for lunch. A race we can't afford to lose. Outsmarting Superbugs. No one should go to the doctor to get well and instead get a life-threatening infection. But 1 in every 20 hospitalized patients contracts an infection caused by medical care, resulting in 99,000 deaths and up to $45 billion in excess medical costs each year. Likewise, Americans count on a safe food supply, but CDC estimates that 48 million people get sick and 3,000 die from contaminated food every year, with costs up to $77 billion. And antibiotics are miracle drugs that make most of us well and we rely on, but bacteria are devising new ways to outsmart them, as in the case of drug-resistant tuberculosis. Breakthroughs in advanced molecular detection, which you'll be hearing a lot about today, AMD, are rendering these and other challenges imminently more solvable. Not long ago, it took months to sequence and months more to interpret a tiny part of a single genome. Now, through AMG, a microchip can do all of this in a matter of hours. How do we harness scientific advances to address these national and global health challenges that result from bioterror, bioerror, and newly emerging superbugs? And I would add, and what is CDC's role in all of this? And to help us interpret that, we've got an all-star panel. Beth Bell is director of the National Center for Emerging and Zoonotic Infectious Diseases at the CDC. In this role, she works to protect people around the world from foodborne and waterborne illnesses, healthcare-associated infections, and drug-resistant threats. She also played a key leadership role in response to the 2001 anthrax attacks, Hurricane Katrina, and the 2009 H1N1 influenza pandemic. Victoria Nahum, a wonderful woman who you get to know today, is executive director of the Safe Care Campaign, whose mission is to prevent healthcare and community-acquired infections. She's working with the Centers for Medicare and Medicaid to support their ongoing work to deliver safer healthcare. And Lance Price is a professor in the Department of Environmental and Occupational Health at George Washington University's School of Public Health and Health Services. Lance works at the interface of science and policy to address the growing risk of antibiotic resistance. And Andy von Eschenbach is president now of Samaritan Health Initiatives and an adjunct professor at the University of Texas, the MD Anderson Cancer Center. And unbelievably, and he'll tell you about it, he served as both commissioner of the FDA and director of the National Cancer Institute. It's quite a panel. Please give them a hand, and then we'll start. And I think I'll start off, Beth, and toss you the softball and say, tell us the magnitude of the problem and a little bit about it.
Sure, thanks, and I want to add my welcome to CDC and to Atlanta. You've heard, I think, already quite a bit about the problem that we face. The problem is that the microbes are evolving. They're evolving in many ways that are unpredictable, and we need the tools in order to be able to evolve with them and to stay ahead of the problem. We've heard about antimicrobial resistance, the fact that we estimate at least 2 million people every year get infections with antimicrobial resistant organisms, and at least 23,000 people die. Foodborne illness, which remains unacceptably common, with about 1 in 6 people every year getting a foodborne infection and about 3,000 people dying, and infections that occur in medical settings, so-called healthcare-associated infections, which 1 in 20 people who go to a hospital, unfortunately, can expect to get. So I think we have seen, there are many different ways that we see, as I say, that these microbes are unfortunately still plaguing us. And what we hope to talk about, I think, today is how these new technologies that we're calling advanced molecular detection can be harnessed to benefit public health and to make these tools work so that we can stay ahead of these microbes in the future. If you'll just give me a moment and humor me, I wanted to share one of my own experiences from more than 20 years ago when I was first starting out as a young doctor working with CDC. I was in the EIS program, which is a training program that I think you'll be hearing more about later on today. I was assigned to the Washington State Department of Health in Seattle, and there I investigated an outbreak of E. coli 0157H7 infections, which were caused by contaminated hamburgers served at Jack in the Box restaurants in the Pacific Northwest. E. coli 0157H7 is a horrible infection. In its worst form, it causes kidney failure and it can be fatal. And unfortunately, it's young children who generally get that most severe complication. We first heard about this outbreak when the local children's hospital told us that there were so many children coming into the hospital needing dialysis that they were running out of dialysis machines. Now, it actually didn't take us very long once we heard about the outbreak to find its source and stop it by the contaminated hamburger meat being recalled. But it took way too long for this outbreak to come to our attention. And by the time it had come to our attention, hundreds of people had been ill, and tragically, 4 children died. So this outbreak, there was a huge public outcry after this outbreak of people I don't think had realized how terribly dangerous foodborne infections could be. And imagine, taking your kid to a fast food restaurant for a hamburger and having it kill them. And so there was, this sort of highlighted the limitations of our ability at that time to stop outbreaks. And as a result, CDC scientists at that time took what was then a very new technology called pulsed field gel electrophoresis, PFGE, and they developed a genetic fingerprinting method for bacteria and other pathogens actually of public health importance. This technology, PFGE, has been widely adopted and has allowed us to make huge advances in terms of our fight with the microbes. In the area of foodborne illness, for example, it's revolutionized how we approach foodborne outbreaks, and we would never, although we've got a ways to go, it would never take us as long to detect one of these outbreaks as it did in the past. And now I think we're at a stage where we have new technologies, and what we're looking to do here at CDC is to be able to once again harness these new technologies for the benefit of public health. The microbes are changing, and we need to adapt with them. As you heard, we are a little concerned here at CDC that we're behind, and we're working very hard to catch up. With, I think, the help of all of our partners, we can harness these new technologies and continue to be able to do what the American people expect us to do, which is to protect them from infectious diseases. So that's, I think, it's a little bit of a tour through the history of the power of new technology when it's harnessed to benefit public health.
Thank you, Beth. So Andy, I'm going to ask you how a nice guy like you could wind up commissioner of the FDA and director of the National Cancer Institute, and now, at least physically, you're here at CDC, at least in person. And maybe if you could look at all those different players in the ecosystem and kind of sketch out for us a little bit what the tools and the organizations are that are dealing with some of these issues.
Well, thank you, Larry. And I do appreciate the opportunity to come back once again to CDC. I would tell you that CDC was, and will continue to be a very critical partner in a combined, concerted, collaborative effort to promote and protect the health of every life, every individual. One of the important parts of that is to appreciate that whether it's NIH, whether it's FDA or CDC, this is a collaborative, cooperative, integrated system. It's being dramatically changed and altered by the incredible progress that's being made in science and in technology. So the new tools that are emerging from some of the research that occurs are tools that have to permeate all 3 of those important components. But the other point I want to make for purposes of stimulating discussion is the fact that the world around those 3 critically important agencies is also radically changing. So to make that point, for example, in the collaborations that exist between the FDA and CDC as it relates to outborne of food-borne illnesses, the CDC plays a critical role in first in detecting the very outbreak itself. Their surveillance systems are exquisite at being able to pick out patterns that begin to identify that we in fact have an outbreak. And then the scientific sleuthing begins with the critical new tools that are emerging, and that brings FDA into the partnership, where the detective game starts to figure out where it's coming from. Is it in fact an outbreak? What is the offending organism? What is its nature? And most importantly, what are the countermeasures that are going to have to be taken? And then we're back to CDC. So it's a collaborative, cooperative effort. And when one looks at some of those threats, very simply to set the stage, the world is changing radically, and it's changing the threats. So we are looking at agricultural systems today where, for example, people expect to eat fresh fruit 365 days a year, all year. There is no such thing as a watermelon season. And now that means these products are coming from all over the world under a variety of different circumstances of production, which lends them to significant threat of contamination and adulteration. So the challenge is global. The other thing that's changing is people today, unlike my grandmother who took took spinach home, washed it 3 or 4 times, and then cooked it, we expect to go to the supermarket, grab a bag, take it home, rip it open, turn it upside down, and the salad drops out along with the salad dressing, which is an entirely different process, a entirely different way of processing food, which once again introduces incredible risks and threats. At the end of all of that, there is a human being, there is a mother, a father, a child that is now at risk. And so it is critically important that, one, we continue to forge these close collaborative relationships in the development and the discovery, development, and the delivery of the science, and two, that we really work collaboratively together to forge the seamless partnerships between the agencies to be able to respond to the challenge and to the opportunity to promote and protect public health.
Thank you. Victoria, we're talking about superbugs, and it sounds like the emphasis is on the bugs rather than on the people. And we started off by saying that these superbugs emerge from bioterror, bioerror, or emerging pathogens, but it's our own health system that has contributed to the increasing emergence of these bugs, and you have, and your family, have had experiences in that healthcare system that tear you apart. And I wonder if you could just tell everybody here a little bit your story. And
I can do that. In a 10-month period between 2005 and 2006, 3 different members of my family, representing actually 3 different generations of my family, were infected by their health care in 3 different hospitals in 3 different states. My father-in-law, Quintino, I had my own infection, and then finally our son Joshua. So at the end of all of this, we lost our son. Our son died. He'd had acquired a gram-negative infection while in the hospital. He was in ICU for 5 weeks, and he had MRSA, and then he got this gram-negative infection. And evidently his healthcare team had been unable to identify Josh's infection in a timely manner. And so what turned out to be a virulent gram-negative infection, which was Enterobacter aerogenes to be exact, it actually caused his brain to swell so much that it was actually pushed into his spinal column, consequently rendering him a permanent ventilator-dependent quadriplegic. Joshua was only 27 when he died, and so So stunned and grieving, we were yet to realize that it wasn't just that we were having a bad year, that the Nahums were having a bad year, because you know as well as I do, you get those Christmas letters from your relatives once a year, and everybody, Uncle Joe got a job, and Marion and Thomas had twins, and that's a good letter. Well, we were having a bad letter year. But it wasn't until a week after Joshua died that I finally realized that it wasn't that we were having a bad year, it was the same thing happening over and over and over again, and the common part of it was the infection. So I'm going to tell you a story. It's just a personal story. I don't get to tell it very often, but this is something behind the scenes. The American public thinks they know the CDC. Like, we think we know what the CDC does, what they do, and what I want to tell you today is that we really don't know them at all. The CDC does so much more than anybody can even imagine, and I'm a personal witness to that. And I know this little story has little to do with AMD, but I just want to tell you what the CDC did for me and my family. Way back, this is, almost 8 years ago, after receiving my phone call, because once I found out that my family had been affected, all over the country, and we'd lost our son, and my husband was in the depths of grief, all I could do was get on the Google and the internet and find out what was going on. And so when I had all these questions, we live in Atlanta, I had no better place to go than the CDC, and I called them up, and they actually took my call, and they invited us to come to meet with them. And so their entire team, Denise Ricardo and Mike Bell and Cliff McDonald, I remember John Jernigan and Arjun Srinivasan, they took hours, each of them took hours out of their schedules to hear us, to answer our questions, to explain the overarching problem of infection prevention in America, which was very enlightening for us. So my question to you is, who does that? I mean, really, who does that? These are big guys. These are important people. And we had a 1-hour meeting with them. They stayed 3 hours with us. Who cares about one family in the scope of all the work they do? Why can they possibly care that much about a family they'd never met before, and yet they did, and they do? I want to tell you that I, for one, will be forever grateful to the CDC. By the end of our meeting, they had answered our biggest question, and that was, what can we do? Just Armando and me. Armando and I, what can we do to prevent infections, to help prevent infections? And you know what their answer was? At the end of the meeting, they said, attach a face and a name to this problem. Because data just doesn't get it. Public doesn't get it when you just throw data at them. They need to personalize it somehow. They said to make it real to real people who can hear with their hearts and who normally don't pay attention to data and statistics. And so we did. Safe Care campaign was created the next week to help American hospitals be safer, prevent infections, obtain best outcomes. And so we do. But in closing, I want to say that what has become my husband's and my life's work was initiated and encouraged by the good and dear people of the CDC, all of whom I will hold gently in my heart till the day I die. And I'm here to tell you that any good work that we do on our path, any good work that we may have done over the last 7 years, originated and was initiated by these people I've just spoken of at the CDC. You can change one thing and you change everything, don't you? So since that time, I keep a very close watch on their important ongoing work. And as every year passes, I watch the CDC face unprecedented demands on the resources, as you can well imagine. And so today you're going to hear about AMD, advanced molecular detection, and even I, as a layperson, not medically trained, am excited at the prospect of this new technology, even though I don't completely understand the scientific underpinnings. But what I do understand is that it will potentially save lives just like our son Joshua's. maybe your life. It will give the CDC the tools they need to continue the crucial work at hand, protecting families like yours and mine, who may live our whole lives unaware of all these invisible dangers around us, and yet whose lives can be tragically affected in one single moment. Thank you so much.
You know, it's a real privilege to sit with you. As we talk about all these abstract ideas, what you've been able to do and how you and your husband have changed everything in your life and the people around you and the impact that you've made. I think all of us who think that we're working on the problem realize that you've been working on the problem much more than we have. Thank you.
I think we're doing
much.
it together, don't you? Yes. We're all doing our part, so thank you.
Okay, Lance, hard to follow, of course. But I told you it wouldn't be easy. I mean, I told you that, right?
You warned me.
You thought I was talking about them. Why don't you help bring us up to date? Give us a little bit of a tour of the horizon of, you know, what we've been able to do so far in using these tools, maybe a little bit earlier generations, and where we're going to go, and then we'll bring it back to Beth and come on back to the future.
Great. Well, I'm here to talk about the technologies and what we're doing at George Washington University, but I'm also a cheerleader for antibiotics, because I really think we lack the perspective to realize how important these things are to human health. How many lives have been saved since they were introduced to human medicine in 1940s, right? And so it's really these superbugs are a battle worth fighting, and we're really in danger of losing antibiotics, the utility of antibiotics against a number of drug-resistant pathogens. You know, we heard a number earlier, 23,000 lives. The CDC came out last year, end of last year, and estimated that, said very conservatively 23,000 lives. Now, I use that number a lot, but you heard from Victoria, these are not just numbers, right? These are real people. And it's real human beings that are unnecessarily dying because of drug resistance, and then countless parents, siblings, you know, friends that are losing their loved ones to drug-resistant infections. So this is a battle worth fighting. CDC has been critical to this, and you know, CDC is amazing at responding instantly to an outbreak and finding ways to intervene and stop that thing from spreading. And I think George Washington University has a very complementary role, and that because we're not tasked with responding immediately, we have time to sit back, not sit back, but lean forward, maybe, and adopt new technologies and try new strategies, new better strategies to understand these epidemics. And so we can be early adopters of new technologies, test them in the lab, use them to dig deeper into epidemics. So understand, what are the major drivers of these superbugs? What are the antibiotic uses that are most threatening? Where do they hide? What are the reservoirs, we call them? Where do they hide? And then how do they spread? And then we can validate those methods and then pass those on to CDC, and that's how we can help one another. And I think that's an important role. And so just a couple of examples. Just in December, we published a paper where we used whole genome sequencing. This is next generation DNA sequencing. It's a revolution. We can sequence bacteria for $50. 7 years ago, it cost $500,000, right? So we can do this now for $50. So we applied this to this new strain of E. coli. So we talked about E. coli that causes diarrhea. E. coli also causes urinary tract infections, so bladder infections, kidney infections, blood infections, kill 40,000 Americans each year. So we studied a new strain called H30Rex. We showed through using whole genome sequencing that this thing just appeared on the scene just in the last 10 years, became resistant to two of our last really good drugs, Cipro and third-generation cephalosporins, spread around the world and now kills thousands of Americans. And we were only able to do that because we were able to use supercomputers and these new next-generation DNA sequencing. We've also made great inroads into understanding and quantifying the impact of using 30 million pounds of antibiotics in food animal production each year, and how that creates superbugs that then spread to people. So we're looking at livestock-associated MRSA, we're looking at foodborne urinary tract infections. And but it seems a little negative because we're only looking back and defining what happened, right? But we're also looking forward. We want to use these technologies, and George Washington University is investing their own money into helping us to use these technologies to also look at diagnostics. So let's start, instead of waiting 48 hours to grow up a culture and then detect what it's resistant to. So we're going to take a urine sample and we're going to put it on a petri dish and wait 48 hours to figure out how to kill it. Now we're going to pull the DNA directly out of that urine. We're going to look at that DNA and we're going to know exactly what the organism is. And then by looking at the genes, we can say exactly what it's resistant to, and more importantly, what it's susceptible to. So that will allow us to revitalize some of these older drugs, tetracyclines, ampicillins, good drugs that we stopped using because maybe a quarter of the infections became resistant. So we moved to the next one and the next one, higher and higher on the shelf. But we've run out of shelves. So instead of driving towards our last antibiotics, we should move back towards these older ones, and we can only do that through these new technologies. So that's one way that we're looking forward, but also looking back.
So these superbugs can come from a variety of different places. When I was at Google, I got a phone call, and my assistant gave me the phone and said, there's somebody on the phone impersonating President Gorbachev who wants to talk to you. And I took the phone, and the guy impersonating President Gorbachev was President Gorbachev. And he wanted to start a new foundation. We had started one at Google, and he came over and had lunch with me at Google. And after he had finished talking about a new foundation, which became something called Global Green, I asked him if I could ask him a question. And he said, yes. I said, it's going to be a difficult question. And he said, yes. And I said, is it true that you allocated $1 billion in a 5-year plan to create a superbug, a chimera, half smallpox and half Ebola? And he took his glasses off and he put it down and he exhaled and he said, duh. And then the translator translated what he said is, it was the most difficult decision of my life, and it was a mistake. And the reason he said he did it was that it was the Cold War, and he said, your President, Ronald Reagan, said he would spend us into the Stone Age, and you were winning. And my generals said I had to have something for my back pocket. So that's one place that a superbug can come from. It can come from conflict, it can come from bioterrorism, which is what that would have been. It can come from newly emerging communicable diseases, the next bat to the next civet cat to the next dinner. It can come out of laboratories, it can come out of hospitals. We need to have diagnostics at every point, all along that path, for every one of these different pathways. Can you, Beth, or anybody who wants to chime in, what's the perfect future look like, or what's a better future look like down the road of technology as we begin to refine these tools for all the things that we need?
Yeah, thanks, Larry. I think a message that I think we all can take just from our whatever 15-minute discussion here is the importance of partnerships and how we all really have to work together. And we've seen, I think, right here a perfect example of where we need other federal partners, we need academics, and we need people who have had the misfortune to personally feel what the horror of some of these superbugs. And as we look forward, I think at CDC, in terms of thinking about how to take these incredible technologies, as Lance explains, you know, we can do something for $50 in 3 hours that it used to take us days and days and millions of dollars. The question is, how do we take that technology and harness it to make sure that it's actually for working for public health? And so that means things like helping to develop common standards so that when one hospital does a test, the result is something that could be understood in another hospital or any number of the other places in a community where when these bugs are spread around. It's how do ourselves at CDC and the FDA, for example, and the NIH work closely together as we develop these technologies. And there are many examples, I think, of how we've already started to do that. One example is the pathogen listeria, for example, where right now ourselves and the FDA and the NIH are working together to try to understand, when we look at the whole genome of listeria cases that are reported to us. And listeria is a horrible infection which is fatal in a large majority of cases. What can we learn together from looking at people that get sick from food products that are contaminated from listeria? What can we learn together to respond faster and to come up with better ways to prevent listeria? Another example actually is in the area of gram-negatives, the horrible story that Victoria told us about the bacteria that killed her son. And if we fast forward to just this last year, we heard about an outbreak of CRE, and you've been hearing about CRE from Tom Frieden all day. There were a couple of cases of CRE reported from a hospital in Colorado. This is a type of CRE that oftentimes comes to us imported from other parts of the world, another theme that we've been hearing about today. And when we used our old technology, PFGE, that I was talking about earlier, we couldn't understand how these different strains were transmitted throughout the hospital. And because we had available to us these new technologies, AMD, we were able to rapidly sequence the strains from the different patients, and we found that there were actually 4 different parts of the hospital that were responsible for transmission. It's that kind of information that not only helps us to stop these outbreaks faster, but it also helps us to understand why is it that some organisms are transmitted in hospitals and others aren't? And that directly affects how we can work better to prevent these infections in the first place. As you've heard with CRE, we have an opportunity to stop CRE from spreading widely around the country, but we're really only going to be able to do it if we all work together. The kind of knowledge that Lance and other people working in laboratories collaborating with us can help us to figure out what are the underlying mechanisms. Why do some pathogens get transmitted and others don't? Why are some pathogens more virulent and kill people and others don't? And then, as I say, working with all of our other partners, and this whole symposium is about partnership, and it's a great opportunity that I'm very happy to have to try to explain what the importance is of all of us working together to really make a difference and hopefully actually be able to get ahead of these superbugs as they continue to evolve.
Andy?
Yeah, I think one of the things that's important to emphasize, especially as we're looking at the opportunities for collaboration between academia, industry, and government agencies, is the whole issue of medical diplomacy. We had the mantra to export our excellence without arrogance. And it really requires the ability for us to reach beyond our borders and to take the excellence that exists and that we've been blessed with here in the U.S. And export that in a way that helps build capacity around the world. CDC has been at the forefront of that, has CDC staff that are in residence in a variety of places around the world. And FDA took a page from that book in 2008, and we initiated FDA Beyond Our Borders, which was to put FDA offices and permanent personnel in China, India, Central America, et cetera. And the concept here is that if we're going to really be able to protect ourselves from these kinds of emerging threats, the kinds of things you were talking about in Contagion, we can't sit here at our border hoping to inspect them out. We've got to build the quality in at the points of production, the points where these things are emanating. And so building capacity and sharing our expertise and allowing them to take the preventative measures that are so critically important, especially protecting our food supply, I think is a really critically important part of the strategy for success, as well as developing the new scientific tools.
Yes, I would like to add to that. You know, so many times in my life and my family's life, when we get sick, you know, you just want to fall into somebody's arms and say, save me, save me. You know, I had meningitis once, and you're so sick you can't save yourself anyway. So, but, you know, the American public needs to get it that we need to take responsibility for helping stop a lot of these resistant bacteria. For instance, you know, stop with the antibiotics already. If your baby has the sniffles, don't go to the pediatrician and demand an antibiotic. because that's a bad thing, okay? We're supposed to have good stewardship of the antibiotics that we have. We're not supposed to add to the problem. So the American public partially needs to be in this. We need to be educated to, when we are given antibiotics, to use them properly, but not to use them when they're not needed, number one. And another thing the public can do is, you know, if you have a loved one in the hospital, if you're in the hospital yourself, you know, there's all kinds of things like, you know, hand hygiene, so you don't pass these bugs around to each other. There used to be an old joke, no, you know, don't go to the hospital because that's where all the sick people are. Guess what? It's no joke, okay? So if you go to a hospital, you're just not walking through these, you know, open glass doors and just, you know, tootling through like it's a mall. It's not a mall. It's a very dangerous place. You have to have rules. You have to know what's going on, and you have to behave differently than you do at the mall. So, and that's another thing that we can, you know, do as the American public to help the CDC keep us safe and prevent these infections.
Andy, we've been talking a lot about antibiotic-resistant organisms, and during your time at the FDA, I don't know if you dealt with the issue of antibiotics being used for animals, and I know Peggy Hamburg is very seized right now with that issue of the use of antibiotics that find their way into the human food chain and, in fact, find their way into creating superbugs by knocking out the antibiotics that can be treated with them.
Well, that gets us back to this, you know, tension between how the world is radically changing in order to meet people's needs and people's expectations. So, you know, we want bigger chickens. We want fatter, you know, turkeys and whatever. Well, obviously, in terms of the production of those food animals, the healthier you can keep them, the more rapidly you can get them to grow in the shortest period of time, the more you're able to meet that demand and that productivity at a price point. So that leads to the use of antibiotics, it leads to the use of hormones, it leads to the use of a lot of things which can be quite harmful then, especially when they're overutilized. So the stress is always to find the appropriate balance and to be able to create that societal context. You asked earlier to make it, bring it home to the audience. I alluded to, for example, the issue of the food supply chain and how production has changed. We like, you know, Steve Bird's here who headed up Safeway, and we would promote cantaloupe as a healthy food that we should be eating all year round. Well, we don't grow cantaloupes in Georgia in the wintertime, so they're being grown in Central America. And in order to preserve shelf life so that they can get up to a supermarket and still be, quotes unquote, fresh, what happens is the cantaloupes are taken off the ground where they're growing in ambient temperatures of around 90 degrees. There's a truck that's filled with ice water, it's a chiller. They take the cantaloupes, put them immediately in the chiller, so they drop the temperature down to around 40, if I remember correctly, in order to stop the ripening process so that they can then be transported and be put in a supermarket in North America. Problem is, when they drop the temperature very quickly, oftentimes the rind will split. And if a cantaloupe happened to be picked up with fecal material on it, because an animal had trotted through the field, and that goes in the chiller, and then that contaminates all the water, any cantaloupe that's skin split has now got bacteria inside the cantaloupe, not just on the peel. And so we've created an enormous public health problem simply because we want fresh cantaloupe in December. Well, how do you balance that? How do you continue to keep those trade-offs in the proper perspective? Well, that is a societal problem, and science can contribute to the solution to that. But some of the other things I told you about in terms of prevention, to make sure that the growers in South or in Central America are doing it the way it needs to be done, or else those cantaloupes don't come into the country. And I happened to personally experience that and had to take phone calls from the president of Honduras, who was accusing or berating me for ruining the economy of Central America by simply shutting off their cantaloupe imports. So it's a difficult problem, Larry, and it's a societal one, it's a policy one, it's a consumer one, and it's a scientific one.
These are part of balancing things that public health has been doing for years. We've only got 4 more minutes left. Let me give Lance a chance to get in.
I think it's interesting that I've reached a state where people kind of wave to me when they say fecal material. I don't know if that's good or not.
All right, I hope everybody heard it. That is going to be the
happens to me
takeaway
all
line
the
of
time.
Yeah.
Just get used to it, really.
Fecal material.
Larry, you brought up E. coli.
Yeah, no, that's great.
I started it. So.
Well, I just want to say that, I do believe that technology can help us, but it's technology and logic, right? So these technologies are going to help. New antibiotics would help us too, right? But if we continue to abuse antibiotics the way we have, overuse them in human medicine, misuse them, and frankly, in some cases, abuse them in food animal production, we're going to just continue to create these superbugs. And the two play hand in hand, right? So, you can seed the system from the food, and it's not until you get treated with antibiotics in the hospital that they appear, right? Babies are born in the hospital, and except on TV, most of them are not conceived in the hospital, right? So I think we can have hope in technology, but we also have to complement that with logic. And then the other piece that I'd like to say, we were talking about boundaries and borders, political boundaries. Bacteria don't wear lapel pins, right? So they don't respect political boundaries. And what I would like to see is the United States take a leadership role on using antibiotics prudently and have good laws, solid laws, mandatory laws on the books, and then lead around the world on this issue, because even, we may be the worst in terms of the developed world, but there's worse antibiotic use in food animal production in other countries. And they're creating drug-resistant bacteria that can spread around the world. And so we need to take a leadership role, and we need to stand up and say, enough's enough.
Beth, you want to take a minute, and then Victoria will take a minute, and then we're done?
Sure. Thank you. I think, as I've said, and I think we've all heard, these are very complex problems. They're global problems. They're constantly changing. As somebody who's worked at CDC for more than 20 years, I've basically spent my life here. We at CDC, it's our job. We work 24/7 to save lives, and we need the best tools in order to be able to do that. And we need to have those tools so that we can apply them in the most effective ways, as you're saying, Lance, so that we can interface most effectively with partners, both in the federal government and elsewhere. And right now, we're right at a point where I think if we aren't able to push forward with AMD, we're not going to have those tools. If you'll humor me for one more moment, I oftentimes use the analogy of a payphone when I talk about CDC and AMD. The payphone was great. We needed it, we used it in communication, but the world changed. We got cell phones, we got smartphones, and although there's nothing intrinsically wrong with payphone as a technology, it's irrelevant. It's become obsolete, and it's become obsolete because the communication world changed around the payphone. And I kind of think of AMD in terms of how we, CDC, need to use it in a similar kind of a way. Technologies like PFGE, for example, are great. They transformed what we were able to do. But PFGE is a little bit like the payphone. And I feel that as we go forward in this complicated world with all these threats facing us, we at CDC really need to be armed with whatever the generation beyond the smartphone is, as the analogy, in order to really do our job.
And the final word?
Okay, so the final word is, it's just anecdotal, and I'm going to tell you really quickly. Who in this audience, raise your hands if you would consider yourself a worker in the healthcare industry. Okay, are any of you working for healthcare payers like insurance companies? Anybody? Okay, that's good. Because listen to this story, okay? A couple years ago, really quickly, they asked me to be on the Wolf Blitzer Situation Room. And so I'm trying to figure out, they want to know what the cost for healthcare is, right? So I'm like, I don't really know, but I want to find out, and I don't want to lie. So I went to this report that had just come out, which is called the Pennsylvania Healthcare Containment Council, like PH4C, right? And I look at the numbers, and the numbers are like ridiculous. I'm like, I can't be reading this right. So I called the director of this whole paper, and I said, you know, it's looking to me like it's over $100 billion when they're saying it's like 6. He said, Victoria, it's more than $100 billion a year just to deal with these infections that are happening in America every single year. $100 billion. I said, I can't say $100 billion because everybody else says 6. He says, say 40, they'll believe you. So I told Wolf Blitzer 40, and now when I go Google it, I say, what's the cost? And they say 40 billion because I told them. That's it.
All right. Thank you, panel. What a wonderful panel. Thank you very much.